Without further ado, I would like to welcome Dr. Jo Dumville up to the stage. Jo is our keynote speaker and will be talking about wound research for patient benefit. Jo leads the Wounds Research Group at the University of Manchester and is also Deputy Coordinating Editor of Cochrane Wounds. Thanks, Jo.
Thank you. Thanks, Heidi. So I just want to thank the Tissue Viability Society for inviting me today. I'm so pleased to be here and to be talking to you this morning. And I'm going to talk about wound research for patient benefit. And this draws together the strands from a programme of research that a team of us did. And I just want to present the headlines and the highlights to you today. Right, let me just get to grips with the technology. Perfect. Oh, let me just find the shiny thing. Brilliant. So, when we started this programme of work, I want you to cast your mind back. It was 7-8 years ago. And I was part of a team, and we'd done a number of large trials that were NIHR funded, and we knew there were still uncertainties in wound care, and we were thinking about more research. But it was difficult for us to prioritise what research to do. We were asking simple questions like, how many people have wounds? What kind of wounds do people have? What are treatments that people are getting at the moment? And finding it really difficult to find answers to those key uncertainties. They feel like the foundations for doing more research, but we couldn't find the answer to these fairly basic questions in the literature. So I'm just going to pause here to talk about a little bit of semantics that I'm going to use in the talk. So when we've done research, we've tended to use, well, let me start. I don't really need to talk to this audience about the different types of healing there are. There's obviously healing by primary intention and healing by secondary intention, healing from the bottom up. We've focused our research on wounds that heal from the bottom up. And we tend to call these complex wounds rather than chronic wounds, partly because chronic obviously indicates the involvement of time, whereas a lot of complex wounds that are healing from the bottom up, like leg ulcers, foot ulcers, tend to be, from the beginning that they're going to take a long time to heal. So this is a term. So when I say complex wounds, I'm talking about these wounds healing by secondary intention, like leg ulcers, foot ulcers, pressure ulcers. Okay, so back to thinking about where we were, which was a lack of information about the basics of wound epidemiology, I guess, complex wound epidemiology. So we did a systematic review of the literature to find out the prevalence studies that had been published to tell us how many people had wounds, different types of wounds, and all complex wounds. We found 48 studies, and they had 3 main limitations. The first was that there was huge variation in how the studies had been conducted. A lot of them weren't done in the UK, weren't contemporaneous, and were of low quality. And there's huge variation in the denominator that had been used, so the study populations that have been the focus of these 48 studies. So, as an example, if we look at venous leg ulcers, so this table presents the minimum and maximum prevalence estimates, so the number of people that had these types of wounds, and it ranges from 0.4%, or let me look at leg and foot ulcers, 10.1% to almost 13%. And this range is to do with different populations being looked at, small populations versus large populations. Lots of variation, really, really difficult to use this literature as it was to find out how many people had wounds. The other thing that there was a lack of was information that looked across the complex wound population. Of the 48 studies we looked at, the majority, well, over half, were in leg ulcers, and then the rest were in other specific wound types. There were very few studies that looked at complex wounds as a patient population. So the picture was very fuzzy, very out of focus, answering these really important questions, not only for research, but for service delivery. How many people have these wounds? What are people being treated with? What we do know is that wound care costs a lot of money to treat. We know that when we were looking at this in 2008, 2009, over £170 million in England in the community was being spent on dressings. And really that cost is only the tip of the iceberg, because the main driver for cost of treating people with wounds is obviously the time of nurses and other staff who treat these people. So it has a big impact. And we know it has a big impact on patients, both financially, through time missed from work, and also the non-financial costs of having these wounds. This is an important issue, and it's important we have the answers to these basic questions. And thinking about the impact of complex wounds on patients and informal carers, there was a real lack in the literature of the patient voice. When we're thinking about prioritising research, what outcomes were important to people who had wounds? We didn't know. What research questions do people with wounds and people affected by complex wounds, what do they want to be answered? And these were all things that drove the aims of the programme of work that we conducted. So we wanted to think about how can we best gather intelligence on complex wounds? How can we we wanted to explore the experience of complex wounds and the outcomes that were important to people affected by it, and assess their research priorities. We also did work looking at the evidence base for complex wounds, and I'm only going to touch on that a brief bit in the talk today, just for lack of time. And just at this stage, I want to highlight that I did this work as part of a team who were based at the University of York, University of Manchester, but we did it in partnership with Leeds Community Healthcare NHS Trust. And that was a key partnership. We couldn't have done any of this work without the support and involvement and the partnership with this NHS tissue viability team and management, which really drove the work forward. So I'm going to talk about 3 items of work, or 3 areas of research that we did. The first was thinking about gathering intelligence data on people and their wounds. So what we did, first of all, was we thought, okay, we're going to try and set up a wound care register. We thought this would be a really useful way to start collecting longitudinal, so prospective data on people with wounds and what happens to them, trying to collect outcome data, trying to find out about people's quality of life, what they're being treated with. To do this, we did a big review of registers to make sure there were no wounds registers already out there, and if there were, what could we learn from them? There was hardly anything. There's some interesting work in Sweden, but everything else in the States had tend to go into administrative databases and then come out again. There was nothing that was longitudinal that we could draw from, really. We looked more widely in the literature and learnt what we could about how to set up a register and what the key aims should be. And those guided the design of the wound care register that we pulled together. And this was a pilot because this is a big job, and we had a lot of questions about the feasibility of doing something like this. And I'm sure you can imagine what some of those issues might be. We weren't sure if this was possible. We didn't know what kind of approvals we would need. We had a lot to think about in terms of the structure of data, how easy it would be to be collected, and how we could facilitate that data collection across the different service providers, especially in community settings. We knew that it would have to link in with routine data collection. That was obviously really important. We can't ask health professionals to collect data over and above what they're doing as part of routine care. Any kind of prospective data collection needed to fit into that model, and we needed to see how feasible that was. We were interested to see how we could work with the IT providers, and we were interested in looking at data accuracy and how to facilitate that. So we worked with tissue viability, district nursing, practice nurses and podiatry. Tissue viability and podiatry at the time were moving on to a model of more mobile working using toughbooks, sort of robust laptops that they were carrying around. And that was linking into increased use of System 1, which had previously been used to capture kind of basic routine patient data, but was seeing increased use at the time to capture more specific wound assessment information. We then had to contend with practice nursing and district nursing still working on paper. So already there we had challenges about how to convert paper data into electronic data and then combine it with the electronic data that was coming in from tissue viability and podiatry. We developed a wound assessment tool. So this was the data that were going to be collected by everyone, in some places by paper, in some places electronically. And I've put the URL for the final report for this whole programme, which I'll refer to at the end, and copies of this and all the other forms and methodologies that we used are contained in that, because I'm obviously going through it quite quickly today. So we collected a lot of data. We tried to collect just enough data to inform service use, enough data to inform research, and data that would have been collected anyway in terms of linking to routine data collection. So what did we find? So we implemented this pilot in Leeds, and the first thing we found that was consent was required from patients, which obviously makes data collection very challenging in the way that you're only collecting data from a portion of people who consent to have their data pulled out of the patient record. We collected data on just under 200 people, and the data that we collected was really high quality in terms of accuracy. We had feedback sessions with staff who said the form was too long, and they were right. But it was a pilot, so it was important that we learnt that. We were able, in the university, to suck the data out of the NHS because we were concerned that that would be problematic. Completeness was a big problem. This is where, as you might expect, we had issues in terms of harmonising data collection and IT compatibility across different services. So where there were gaps, when people moved around different services for treatment, it was hard to collect data that followed them. So that prospective element was really difficult, and the IT was problematic in terms of linking. Another key issue that was raised by staff and that we noticed as well when trying to analyse the data was if people had multiple wounds. Trying to collect data on different wounds was really difficult. But it's really important that we find solutions to this because we need these kind of data. So we're working with other people. Leeds is continuing working on this. And there's really interesting work at the moment in Salford around electronic data collection in the community that spans this. So it was an interesting pilot. It raised a lot of questions and challenges about doing this, but also I think proved that fundamentally it is feasible with the right support. So I think this just summarises what I've said. I'm getting ahead of myself. But we still wanted these data. The register wasn't the way to go. It was an interesting feasibility study, but we couldn't get the data we wanted. If nothing else, because we needed to consent people, we couldn't get good epidemiological data on everyone with a wound. So we did a multi-service cross-sectional survey to get the data we needed, and we aimed for comprehensive cover. So we wanted to find out about everyone who had a complex wound in Leeds over a 2-week period, and we involved everybody. We had prisons, we had hospices, we had hospitals, we had all community providers, mental health trusts, private nursing homes, NHS nursing homes. We, GPs, just one GP practice didn't take part. We were as comprehensive as we could be. It was a huge piece of work in terms of getting quite simple data collection integrated over a whole city. People were included in the survey if they had at least one complex wound, and we had careful definitions that people followed about identifying wounds during the survey. The survey didn't require consent because it was completed away from patient bedside, so it didn't involve any contact with the patient. It was recording that they existed and were being treated within a service. We had complex systems to deal with duplication, obviously if patients were being treated in multiple settings, and the data were analysed to produce prevalence estimates. So the point prevalence of all complex wounds in Leeds was just under 1.5 per 1,000. So that equates to about 1,100 people in Leeds having a complex wound at any one time. And if you take that up to a UK adult population level, it's about 75,000 people with a complex wound at any one time. We've obviously broken the data down in lots of different ways by age. This is by wound type. So the most prevalent wounds were leg ulcers. Of all the different wound ulcer types, of all the leg ulcer types, the most common were venous leg ulcers, and this tracks with existing literature. About just under 70% in this survey of leg ulcer patients had a venous leg ulcer, and pressure ulcers were the next most common prevalent wound. So this is the form we used to capture this data. Again, it's readily available. And the great thing is that we then used the same methodology in Manchester. So across several sites in Manchester as part of Clark, a piece of research and practice and implementation exercise, we repeated the exercise, a refined version of the exercise essentially, and found very similar results. This was just focused on the community. So obviously this is really reassuring. We think it's a robust methodology, and we found similar data in Greater Manchester, about 1.6 people per 1,000, and a similar pattern in terms of the types of wounds, the types of complex wounds people had. So as well as information on the number of wounds people had, we also got really rich data on treatments being received. We could tell how many people with a leg ulcer or with a venous leg ulcer were having compression, how many people had ABPI assessments, people at risk of pressure ulceration, what support surfaces did they had risk assessments been done. We found the grade of staff that were delivering care in different environments, where care was being delivered, how much care was being delivered in the home. And especially in the work in Manchester, it's been really interesting to look at variation. So we're doing a lot of work around the variation in things like use of antimicrobial dressings, use of compression for people with venous leg ulcers, use of ABPI, looking at different sort of CCG or provider levels. We've got multiple ones, and the spread of variation and what underpins that is really interesting. And also thinking about comorbidities. Often wounds are symptoms of underlying problems that people have. And looking at the whole person, it's important to understand this multimorbidity issue. And people with wounds are obviously, or people who have wounds or at risk of wounds are obviously often patients with complex needs. And considering that and how the wound care fits into that is something that we're thinking about. And this provided really useful data. We also wanted to focus on IV drug users. There's not very much information in the literature about this patient population. When we did our survey, we also worked with no fixed abode teams and people working with homeless service users to make sure that we got into these hard-to-reach groups to try and capture data on the prevalence of former and current IV drug users, the prevalence of complex wounds. And we found a figure of about 5.6 per 1,000, so it's obviously a lot higher than the base rate in the general population. So we thought this was really important data, again, to have in the literature because it's not there or it wasn't there previously. So simple, large-scale data collection that's resource-intensive at the time but produces really, really important data is what we were aiming to do with this programme. So, finally, the last main bit of work that I'm going to talk about today was thinking about the outcomes of research that are important to people affected by complex wounds, health professionals, patients, and their informal carers. So we wanted to look at this, and then we also wanted to work with patients and health professionals and carers to think about research questions that we should be looking at. So in terms of the methods, to look at the outcomes that are important to patients, we did semi-structured interviews. So 33 people with different complex wounds were interviewed about their wounds, living with their wounds, and what outcome they wanted for their wound and themselves. And then we also undertook a James Lind Alliance pressure ulcer partnership. And the James Lind was set up in 2004. And it's an organisation that tries to bring together different stakeholders to explore shared healthcare uncertainties that can be answered by research. So rather than just letting researchers or specific people set research agendas, it's trying to bring in wider participants into the process so that it's a more full and realistic picture of the uncertainties people have got. So, just thinking about the findings of the semi-structured interviews about what outcomes are important to people with wounds or people affected by wounds, and I just need my notes for this. So, healing, as you may expect, was the key outcome. People wanted their wounds gone. And when we asked people one thing that they would kind of change about having their wound, what was really interesting is there wasn't an incremental answer. It wasn't, I want my wound to get smaller, I want to see progress. It was emphatically, I want to get rid of it, I want to take it away completely, I want not to have it full stop, I just want for it to heal. People didn't want to have their wounds anymore. There were some interesting comments around people wanting to be cured, which in some patients is obviously challenging. There was obvious tension for health professionals treating, or the health professionals we interviewed, the 12 health professionals we interviewed, around patients' desire to heal, alongside the challenges of this in people who were going to have wounds for a long time and potentially had unrealistic expectations of healing, and the tension between trying to achieve healing outcomes with managing people with long-term conditions, complex patients with multimorbidities. And that was obviously a source of, in the people that we interviewed, was a challenge. And patients talked a lot about their desire for healing, but also the difficulty of living with wounds, as you might expect. They were troubled by the socially inhibiting consequences of having a wound. It had a huge impact on people's quality of life. And we know this from the literature to a degree, but these findings, as well as the work on important outcomes, really added, or has added, a level of depth and volume to the patient voice that I think is really important. So what we went on to do, we heard from patients that healing was an important outcome. So we wanted to look at the literature to see what we were measuring when we were doing research, especially research around treating wounds. So we did a big systematic review of all randomized controlled trials that had been published between 2004 and 2011 that looked at treatments for leg ulcers, pressure ulcers, and foot ulcers. So we found 167 trials, individual studies. We then extracted a lot of data on what those trials looked like, what they were investigating, how many people had they had in them, how long they followed people up for. We were looking at kind of the methodological quality and the validity of the studies. And we also looked at what outcomes they collected. So 24% of these trials had complete healing as a primary outcome. So a quarter. So what you might think, understandably, is, well, maybe there were other outcomes, important outcomes that these studies were measuring that weren't about healing. And what we found was there was 7% of these studies that had a primary outcome, but was a non-healing outcome. So it may have been around infection, reduction of infection, or prevention of infection. There were 28 studies that had what we called a surrogate healing outcome. So this means that they measured things like reduction in ulcer size, % reduction, a kind of measurement of the pathway to healing, but not complete healing. And this can be appealing for people when they're doing research because you need less follow-up time, so it makes research cheaper, because if you're not following up until time to healing, until a wound's healed, you obviously have shorter studies on average. But the risk is, we know that patients are interested in their wound going, completely healing. And there is some data that suggests reduction in size predicts healing, but that's not absolute. The data's not so robust that we can assume that if someone's wound's getting smaller, it means that they heal. Certainly not in the context of evaluation research. And 40% of studies didn't have a primary outcome, which is an indicator of limited methodology. And this is quite, it's obviously methodology, doing trials, it can feel quite abstract, but I think we're all kind of customers of using RCTs, and either if we're patients or potential patients, healthcare professionals, and we kind of need to demand that they're of high enough quality to be fit for purpose, to answer the questions that are important to the people that are affected by the conditions that we're looking at. And when we looked at this cohort of papers, that didn't seem to be the case. So I said we then did a James Lind Alliance pressure ulcer partnership. This involved asking people whether are at risk of pressure ulcers or affected by pressure ulcers what research they thought was important. The process involved surveying people, drawing together people into a partnership, which was a piece of work in itself, and then supporting that group of people to, on paper, and then in a face-to-face environment, suggest uncertainties around treatment. So thinking about the population that they're interested in, interventions that people might have questions about, and the outcomes of interest. And then ranking those into a set of ranked uncertainties that could be answered by research in relation to the prevention and treatment of pressure ulcers. So we ended up with the top 12. This is the top 5. And the top question ranked by patients, health professionals and carers was how effective is repositioning in the prevention of pressure ulcers. And then the top 3, the second 2 were around involving patients, families and lay carers in pressure ulcer prevention, and then education of health and social care staff on prevention. So the top 3 were around prevention rather than treatment. Actually, the top 5. So, and these are the other uncertainties, which I'm not going to read through at the moment. But they're all contained in the report, the URL I put up earlier. So in terms of conclusions, I think the main headlines are routinely collected data that gives you a prospective insight into people you have with complex wounds, how they're treated, and what happens to them would be fantastic. It would be possible, but it's not possible at the moment. But hopefully that's what we're working towards in the future. We have a framework for good cross-sectional data capture, which provides really, we think, good, accurate and useful data around the prevalence and treatments of complex wounds. Healing is a key focus for patients. We need to make sure that in research, certainly, we're capturing the outcomes that are important. And we need to make sure that the research agenda reflects the uncertainties that people affected by complex wounds have, capturing them as we did in this pressure ulcer partnership, but also then taking that further to see what research has been done around those uncertainties, and then to inform the research agenda when more research is needed. So I'm sure everyone will be ecstatic to have their picture blown up on this screen, especially the ones that are here. So there are a huge team of people involved in this, and the additional research I haven't spoken about today, which was around evidence synthesis, bringing trials together, complex network meta-analysis. We had statisticians, health economists, we had health professionals, some of whom seem not to have their picture online. Good for them. So it's just to acknowledge this work reflects the input of a lot of different people, and not all of them are listed here. This is our report that's freely available, all 300 pages of it. And this is the disclaimer that I have to show, and to acknowledge the funder, the NIHR, who supported this programme of research. Thank you.
Thank you, Jo. That was really interesting. Does anybody have any questions for Jo? We're going to take questions for Jo now rather than at the end of this session. I'm hoping people do, because we have a really fun gadget in the room today for questions. a throw mic. So be prepared to catch it when it comes towards you. And I believe there's a cross on it that you have to talk to. We've got a question down here at the front with Nikki. No? Oh, sorry, there's one there. Sorry, already up with a mic.
Hello, really enjoyed your presentation. Thank you very much. I'm Julie, I'm a nurse advisor of Hartman. I felt what you were talking about with research around wound healing was very interesting. And I think it's important to recognise that what patients define as healed is sometimes different to what nurses define as healed, because wound healing actually continues a long time after reepithelialisation. So sometimes some of the problems with research around where healing is defined, and I think that that's the woolly area really. Do you have any comments on that? Did you find any issues with that in the research?
So, no, thank you. It's a really interesting and important question. And I think underpinning my answer is the importance of involving the right people when you do a research project, because we need to have definitions of what a healed wound is, and we need to think about how we measure that, and thinking about recurrence as well, and when a wound's healed and when it breaks down and over what time period. And there's no point me as a non-clinician plucking a definition of what a healed wound is or looks like out of thin air. We need to work with people like you in collaboration to make sure that we have the right definitions, and with patients as well, to make sure that we have meaningful and well-defined outcomes in the research we're doing. Absolutely.
Absolutely, and it is a real challenge that there's no sort of key definition that we all use, because some say on reepithelialisation, some it's a month and some longer.
Yeah.
So it's a real challenge to identify.
It is.
Vicky, did you have a question? Yeah. Catch the ball. Yeah.
Hello.
Hi. So it's more of an observation really than particularly a question, but I just think about the work that's going on at the moment around how we level off the relationship between the healthcare professional and the patient suffering. And I think, you know, this sort of traditional top-down approach of we know best and this is what the research evidence says is good for your leg ulcer or your pressure ulcer, isn't necessarily the right approach in terms of levelling that relationship. And I think what would be really useful going forward is about how we adjust our approach to a more sort of motivational interviewing, health coaching approach, where actually we're exploring what the patient's knowledge of their wound is, what their background is, so that they're making a real contribution to the work that we're doing with them or alongside them to support healing, because it's that imbalance that causes the frustrations for both parties, isn't it? The frustration that as a nurse or a clinician you can't heal a wound, and the frustration for the patient that every nurse that comes in promises something different, and they hope that that's going to be the thing that's going to work. When in actual fact we know it's the fact that it's around lifestyle sometimes, or it's around comorbidities. So that kind of not my monkey, and using those skills I think is really important for this kind of work going forward. But thank you, Jo.
Thank you. I think if we've got one more quick question at the back, yeah? Una? And then we'll finish with that one.
Thank you. I was rubbish at netball. Thank you very much. Just a very quick comment back to this end. Just one quick question for you, Jo, if that's all right. Unilaterally Leeds, though I had no involvement with this project at all, just want to declare and I've never worked clinically in Leeds. But the lady over there who was asking about outcomes, you might be interested. Sarah Hallis is talking in the REN programme about, she's looked at all the different outcomes. I think it's for venous leg ulcers. Yeah. If you can't get there should be an abstract in the programme. And I seem to remember it was in the hundreds. She found it was shocking. But the question I wanted to ask you, Jo, was in the piece of research you did, I'm just thinking back to the guest paper that was published earlier this year, and what shocked me was the very high proportion of leg ulcers that didn't have a diagnosis attached to them. I think it was over 50%. I can't remember off the top of my head. Looking at your slides, you didn't state how many were undiagnosed in Leeds, and I wondered if that's because Leeds do things really well, and actually nobody gets through without a diagnosis, which is quite possible. They're very, very good in Leeds, and they may well be equally good in Manchester. Or does that raise a question about whether the Leeds population is sufficiently representative of elsewhere, or the care in Leeds is sufficiently representative? And can we generalise, I suppose, is my question.
Yeah, no thanks. It's a really good question. And there's the data we have has obviously been collected in quite a different way from the data that's reported in Guest. And I think that probably largely underpins the difference. So that paper uses thin data, which is primary care data, so data collected in GP practices. And so you're relying there on the use of read codes and other coding systems to record a diagnosis. And that's not very good in primary care. Evidently, that will be some of the reason for the lack of information about the type of wound, because we were going straight to source. So we were going straight to the patient records, the people treating. So we have people, for the majority, we could say, well, we think it's this, we think it's this, we think it's this, within the definitions that we've got. So we were getting more kind of accurate data collection. And we found the same in Manchester. So I think the Leeds being unrepresentative on its own could be a potential risk that we'd need to explore, but the reassurance of doing the work in Manchester is obviously encouraging. So I think the main difference is much more likely to be the way that these data were collected, which were quite different.
I thought that might be the case. Thank you.
Thank you, Jo.